testimonial by the patient's wife, who very kindly left a little post on my Facebook page. And so this gentleman contacted me last Friday in a lot of distress, actually. He was complaining, his main complaint was actually otalgia. So otalgia is the medical term for earache. Of course, he was also experiencing reduced hearing. On the phone, he explained to me that he suffers from cauliflower ear. So for anyone who doesn't know what cauliflower is, cauliflower ear in America, actually, I believe it's called wrestler's ear, and it's trauma, repeated trauma to the pinna. So the pinna is the external ear, the satellite dish. And post-trauma, the cartilage of the pinna fills up with blood. And that blood does need to be drained away by an ENT doctor as soon as it has occurred. If not, it can cause long-term complications, and it can be quite serious. And this repeated trauma just causes swelling of the external ear, which meant in this case the entrance of the ear canal itself is very narrow. The medical term for cauliflower ear is perichondral hematoma. In addition, he also advised that he has a mastoid cavity. So a mastoid cavity is an enlarged ear canal for the reason that the posterior part of the ear canal, the mastoid bone, which is porous, has been surgically drilled and removed due to an infection, and that infection is called mastoiditis. So in some cases, if you have an outer ear infection or a middle ear infection, that infection can get absorbed by the mastoid bone. And if that mastoid bone, if that infection is not treated either by antibiotics, or if it's come to the stage where it needs to be surgically removed, if it's not, the mastoid bone obviously makes up part of the skull, and it can cause this infection spreading to the brain, causing meningitis possibly as well. So it's very serious. In addition, he also mentioned to me on the phone that he has got a long-standing perforation of the eardrum. So perforation obviously is the whole of the eardrum, which meant that this patient can't use earwax drops because if these drops do enter the middle ear through the perforation, some of these drops are known to be ototoxic. So ototoxic drugs are those drugs that can cause permanent hearing loss. So in this particular client, those drops can enter the middle ear through the perforated eardrum and then get absorbed by the organ of hearing called the cochlea, causing permanent hearing loss. So it was a real challenge for a number of reasons. So again, with cauliflower ear, not only is the ear canal entrance very narrow, it's also very stiff, so it's not flexible. It's very difficult to retract this ear. And previously you were seeing me using a standard Zollner suction probe, and you can see this is not wax. It's keratosis obturans, which again is another feature of this case which makes it more complicated. Keratosis obturans is a buildup of dead skin, what we call keratin. In most cases, you can compare the skin in the ear like a snake skin. It sheds, it naturally migrates, and then you get another layer of skin. But with keratosis obturans, this skin, as it sheds, it doesn't migrate outwards, and it causes a dead plug of skin remaining in the ear, and it is one of the hardest things to remove. I should add, this video is not for these armchair experts or those people who have got degrees, YouTube degrees on earwax removal or Google degrees. This is a very highly complex procedure, and sometimes this type of procedure is performed under general anaesthetic. So I just wanted to point that out, because I can imagine some of the viewers, oh, why don't you use this instrument? Why don't you use that instrument? Like I don't know what I'm doing. So yeah, if you're one of those experts, please just turn away. You won't find this video of any interest at all. So the skin itself, you can tell it's skin. You can tell by the complexion. You can see a lot of white, fresher skin actually. So I'm just using an ear hook here, and what I'm trying to do is loosen these skin adhesions from around the ear canal wall. So here I'm just going to the roof of the ear canal, and this plug of skin, you can almost describe it and categorize it as almost like a piece of chewing gum that's stuck in on a hard surface and it's dried up a bit, but it's still a bit elastic. So whenever you get an instrument like an ear hook through this plug of dead skin, there's a lot of elasticity, and I don't know whether it's visible just by watching the video, but when you're performing the procedure, you feel the skin bouncing back. It's a tug of war. This plug of skin does not want to come out of the ear. And also with this patient, as I said, he's got a very enlarged ear canal, probably 3 times the size of a normal ear canal, and he's also got a very narrow entrance. So if you do the physics behind it, you're trying to remove a large plug of dead skin through a very narrow aperture, so it's very, very difficult indeed. So I've resorted to the Henkel forceps here. I wasn't using crocodiles, because with crocodile forceps, I find with soft, spongy dead skin, it just tears the skin and just releases little pieces, segments. So Henkel forceps have a larger surface area, so you do get a lot better grip. So I did manage to get a bit out with the Henkel forceps, but I've just gone back in with the Zollner suction probe, and you can just see how spongy this is and how adhered it is to the canal wall. And we're at the base of the ear canal here. And the other issue with keratosis obturans, so this client's already got an enlarged ear canal due to their mastoidectomy. However, dead keratin itself can cause erosion of the canal wall, the bony part. So it's quite possible that this skin is actually, because it's been in there for a long, long time, it has actually widened his ear canal even more. And I'm just, as you can see, I'm working at the back of the ear canal here. This is the mastoid region, and I'm really just trying to, as much as I can really, trying to loosen this adhered, spongy skin off the canal wall, but it is a very, very difficult case. So I'm really stretch this ear open as much as I can, and this is the back of the mastoid. His original ear canal is way off to the right, off screen at the moment. And I'm just trying to get in behind using a Jobson horn and just elevate the skin, loosen it. You will find, I'm not sure where it is in the video, but with this dead skin, when you do lift it off the canal wall, you do get what we call contact bleeding. So you can think about if you've got a blister on your finger and you're peeling off this dead skin, you can sometimes get bleeding. And it's purely due to the skin being stuck, adhered to the canal wall, and that compression. Imagine this big plug of dead skin in the ear, and it's just growing and expanding, and the amount of compression that's in this ear, and that was what's causing this gentleman's altalgia, his earache. So I did manage to loosen some of this using the Jobson horn, but I've just gone back in with the forceps. But again, even with the forceps, even with the Henkel forceps, it was just tearing little pieces of dead skin away. This plug really did not want to leave and vacate this gentleman's ear. So I've just gone in with an ear hook, and I've got a rather large piece there. I'm just going to let you watch for a couple of minutes because it is a long video, and obviously it's going to be a lot of talking my end. But again, I'm just going in with the ear hook here, just trying to lift this plug of skin from the base of the ear canal, and I'm just on the posterior canal wall here in the mastoid cavity. Again, just trying to elevate and retract this plug of skin from the canal wall. I'll just let you two watch that for a few minutes. Okay, so I just thought I'd come back and explain. So this part that I'm focusing on, there is a cave there, and there's a crater. So just in the middle of the screen right now, that's the client. You can see the cartilage. So that's the client's original ear canal wall, and to the left of it, where the suction probe is, that's the mastoid cavity. And it's difficult to see, but there's a trench there, and this plug of skin's right at the base. And I'm just trying to gently lift this using the suction probe. I'm really tugging at that. You can see how spongy and elastic this skin is. And with dead keratin, it tends to coil. You may be able, and you get ribbons of dead skin, and on occasions you will be able to visualize that as I'm removing the skin and lifting it away from the posterior canal wall, you'll see these ribbons. People with mastoid cavities and also people who suffer from keratosis obturans, they're normally evaluated at ENT outpatients on a regular basis, because people with mastoid cavities, they generally do develop keratosis obturans because that enlarged cavity doesn't lend well to the natural migration of skin as the skin sheds from the ear canal. So, but this client, I think the last time he was seen by an ENT was 17 years ago. So this build-up has been there for around 17 years, which is a long time. So at the end of the procedure, I did advise this patient to come a lot more regularly to see me, and we've agreed to see him in 6 months in the first instance, and from then we can gauge how often he would need to come back. It would be a lot easier if I was able to use some drops. So sodium bicarbonate drops works really well with dead skin, but as I mentioned, this client has got a known perforated eardrum, so we want to avoid wherever possible instilling any types of drops. I've just gone in with the Jobson horn, and again I'm still working very hard at just lifting this plug of skin off the canal wall, and you can begin to see it loosen around the canal wall. You can just see the fresh layer there in between the darker, crustier skin in the middle. And at the back there, you can just see some contact bleeding. So as I'm elevating and retracting this dead keratin from the canal wall, because it's so compressed, you can see a bit of bleeding occurring there. And just behind this plug of dead skin, the firmer skin, you'll see very damp. In here you can see it. It's very damp and moist, and that can happen with dead skin. It can eventually get very damp and wet, and that is obviously extremely humid. You can imagine it being completely blocked for many a year, and beyond the outer layer, the ear does become very damp and humid. So I'm just going in with the standard Zorn, the suction probe here, just to vacuum some of that dampness. And at the top there, you can see a bit of bleeding there. And it's when we lift this epithelial layer of keratosis obturan off the canal wall, it's what we call contact bleeding. It's nothing that we've done. We've not grazed the ear canal in any way or caused any trauma. It's quite common with cases of keratosis obturans. And if you can see the dead skin that's on the posterior canal wall, the back part, it almost looks like wax. It's darker, but that's not wax, that's oxidized, which means that piece of skin, that keratin, just to the left where the suction probe is, that has been in that ear for a long time. The other shades of dead skin, so the lighter brown, the white, it's all fresher skin. Now when I say fresh, it doesn't mean it's just been secreted in the last few days or weeks. It still could be in there for years, but it's what I'm making reference to, that darker piece of dead skin has been there for a lot longer than this lighter shade. And I've just there with this suction probe, just trying to get a grip, really tugging at this. And as I said before, it's like chewing gum in the ear. It's no better way of explaining it, and it's very elastic. And it's almost like a rubber band consistency. You're pulling the rubber band and someone's holding it on the other end, and it just doesn't want to let go. So I've gone in with the Jobson horn. I'm just trying to get in behind and separate this, and just trying to get around this big plug and just almost like a spade, a shovel, pull this out. I've got a little piece there. Just going to re-enter again. One of the issues as well with dead keratin that's soft like this, whichever instrument you use, whether it's an ear hook or a Jobson horn or forceps, you kind of slice through it. You're not getting big chunks out. You can see there that piece of dead keratin was very damp and soft. And as I mentioned before, when you remove keratin, you do get some bleeding. So that was some of the keratin that we removed, and you can see So this is the mastoid cavity. You can see the cartilage of his original ear canal wall just to the right. So this is his extension almost, his extended ear canal. And it's just from that cave area. You got contact bleeding, and his blood is just seeping out from the bottom, which just can make the patient isn't in any pain whatsoever. Actually, he was enjoying the procedure because he felt as though every time I was removing a piece of keratin, it was relieving the pressure inside his ear. So he was actually cheering me on and praising me every time I got a piece of keratin out, because he was finding piece by piece his symptoms were improving. And you will notice when the ear is a bit damp and there's a bit of blood, it does make the view a bit blurry. I can still see exactly what I'm doing, but it does cause a bit of blurriness. On occasions I will come out and I use an alcohol wipe to wipe away and clean the distal end of the endoscope. And the distal end is the tip, it's the bit that we insert inside the ear to obtain the view. You can see there I'm really tugging away there at the dead skin plug, and it's I think I'm going to be going in a moment with some forceps just to see if I can get a grip and retract this and extract it from the ear, but it's still very tough in there. So I'm just working on his original ear canal here. This is the front part of his ear canal, and to the left is his mastoid cavity. But this is, if you didn't have the mastoid cavity, this area here would be his original ear canal. And you can see at the top, beyond this piece of skin, it was a bit damp and wet, and that's because of the humidity. And over time this dead skin can get infected, so I've just gone in with the forceps. I managed to remove a piece there, but it kind of teared it away. It didn't remove it in a big piece, so I'm just going back in there. You can just see it's just, with people often say, why don't you use forceps to remove it, but with this consistency it just tears it. It's quite damp and soft and elastic. If it was a solid hard piece of keratin or wax, yes, you can get a grip and just pull it out. You can see how wet it is here. So I've just got 3 small pieces there, and I could tell it was a bit damp. So we're just approaching his eardrum there, and if you remember, the patient did alert me that he has got a perforated eardrum. So again, we're just going to be cautious, careful here, because we can't see the eardrum, but we know the eardrum's behind this piece of keratin that's quite medial now. This almost looks like a normal procedure at the moment, because it just looks like it's a normal ear canal, but as you can see on the left hand side, he's got a much widened ear canal, and you can see all that kind of fluid, damp, moist skin, all that fluid that's collected because of the humidity behind that skin. It's just seeping out there. So he didn't have an active ear infection of his eardrum. The eardrum itself was dry, and you'll see that in a moment or in a few minutes. That wasn't infected. This moisture, it's just due to sweat and humidity and the dead skin that's becoming kind of almost slightly infected itself. We're still pulling away there. And the reason for me having little intervals and not talking throughout the procedure, this procedure is about an hour long, it's yeah, it can be very difficult to talk for an hour. So I'm just gonna, at key moments, I will kind of interject and kind of just narrate over it, and you can see here how much pressure I'm putting, how much I'm tugging this, trying to release this from the back part of the ear canal. I'm making some progress there. So as ever with an endoscope, we've got a wonderful view, and that's one of the benefits of an endoscope. You have a wide field of view. If you were using an ENT operating microscope or some head magnification loops, you wouldn't obtain this view. You wouldn't be seeing the whole ear canal. you'll see a small section of the ear canal itself, and that's because with microscopes, although you can get a very magnified view, the field of view is very narrow, so the specialist will be using a speculum, and they'll put that in the ear and they'll be positioning the speculum around, trying to see different parts of the ear. So with a microscope and a head loop, you'll get, it's almost like jigsaw pieces, you'll get little jigsaw pieces and you have to put it together to get the big picture, and you get that by moving the microscope around. One of the great things about the endoscope is that you just get the whole view in one panoramic image, and that's the beauty of an endoscope, and that's why it's being widely used now within ENT as well. Endoscopic ear surgery is dramatically and exponentially on the rise. But as with most things, when we first launched endoscopic earwax removal in the UK, the old school, the old guard, were very defensive. I think also because I was quite young as well when I launched this, there may have been a bit of people kind of thinking, well, we don't want him to do well. And it's been 5 years now since we've launched this in the UK, and we've trained a number of specialists, GPs, ENT specialists, audiologists, hearing care specialists, ENT nurses, not only in the UK, but we've had a few people come from America, Canada, South Africa, Australia, and I think New Zealand. So as with most things, it just takes a while for people to appreciate actually this has many, many benefits, and not just turn your nose up at something because it's new and novel, and maybe because some people wouldn't be able to perform this procedure. We do find a lot of people who have been using microscopes or head loops for a long time, they tend to struggle at first, and that's because their brain's used to doing it in a certain way. But over time, the majority of, and I wouldn't say everyone, but the majority for sure of specialists who were previously performing microscopic or head loop earwax removal and have come on our course, they have now tended to use the endoscope a lot more than the other two techniques. And there was a paper, a clinical study, I think in 2006, conducted by an ENT surgeon called Mr. Potier, who sadly passed away last year. And he compared endoscopic versus microscopic earwax removal in a clinical randomized trial. And he found, and his team found, that endoscopic earwax removal was quicker, more comfortable, and less difficult for the specialist to perform, and there were significant findings. And however, in the UK, most ENT specialists already have an operating microscope, so there's very little logic for them to revert to an endoscope. But in the last decade or so, you're finding that a lot of audiologists like myself, ENT nurses, are also performing the procedure. And another benefit of an endoscope is that it's portable. So a lot of nurses or even audiologists and hearing aid dispensers, they do offer domiciliary visits. You can't really cart an ENT operating microscope at the back of your car. It weighs a ton, extremely heavy. And with our technique, the iClearScope, we've developed a little carrier case, very portable, very easy to use, a small blueprint. So you can see us making slow but steady progress, and with these procedures, it is patience. Patience is a virtue. There's no shortcut. I wish there was. I don't enjoy spending an hour removing wax from a patient's ear. I can sure tell you my hand does it, my arm, because it is extremely fatigued and tired after this procedure. But there's no other way. As I said, can't use drops. It's got keratosis obturans, which is the hardest thing to remove from a patient's ear. Quite often these procedures are performed under general anaesthetic by an ENT consultant. It's got a mastoid cavity, it's got cauliflower ear, so the ear canal is very, very narrow, so it couldn't get more complex, I wouldn't have thought, really. All the elements were against me, but as I said, if you've got with earwax removal, you do need a lot of patience. Quite often I read all these comments on YouTube, why don't you just vacuum it? Well, if it was that easy, we could train a monkey to do it. I don't think people appreciate how complex earwax removal can be. It's not a case of just putting a vacuum cleaner in the ear and sucking everything out or hooking it out. And I bet most of these people who make these comments wouldn't be able to get the instrument in the ear or both instruments in the ear. So it is a complex procedure. So I've just gone in back with the Jobson horn, but you can see it was a lot of kind of fluid at the base, a lot of bleeding there. Client again, complete comfort, not experiencing any pain. Obviously, if he was, we wouldn't have continued. But it was again, it was cheering me on here. I remember this particular point because this is where he was experiencing his altalgia. And as I was lifting this keratin off the canal wall, he was feeling that release of pressure and that compression. It was getting bearable for him. And it was really willing me on here. I specifically remember this point because this is the part where he found was causing him extreme discomfort when he attended, but it's so difficult. He's got a big crater below there, and the skin plug, it's just literally a dip. So I thought it's a good idea at this time. If this is the first time you're watching one of my videos on YouTube, please do subscribe. I have over 150 videos. I have different playlists available of different types of procedure. I think my YouTube channel now is approaching 140 million views. So yeah, please do subscribe. You can also click the bell icon. That will notify you as and when I upload new videos. I probably don't upload as many videos as I should. It's just because I'm very busy, and these videos do take time. I generally am fully booked most days, and again, I'm just staying behind after clinic because of the pressure applied upon me from all my Facebook followers who are really encouraging me to upload this video as soon as possible. And if you're watching this on Facebook again, please do like the page, follow the page, leave a comment. That also goes to YouTube. Feel free to like and comment on the video and share and forward this video on. Sorry, I've not edited this part. Just probably missed it. So I was just going in with the ear hook there, got a piece of keratin out. So if this was a normal ear canal, we would have finished by now because the amount of wax, or not wax, sorry, dead keratin I've removed so far, it's an incredible amount, and you'll see that at the end of the procedure. I've got all the still images. So it's almost like I'm doing 4 ears in one go. And this is a piece of this hard keratin, this keratin that's been in there for a while. It's oxidized and it looks like wax, but it's not. And I managed to remove some of that using an ear hook. And again, apologies I didn't edit this. I must have just missed this bit out. So when I'm out of the ear, it's I'm just either cleaning the instrument, wiping the tip of the endoscope, or either myself or the client just wanted a little break. You can just see me there wiping the distal end with an alcohol wipe just to make the view clearer. Hopefully this is the only part where I have forgotten to edit, and I think the rest of the video I have edited out all the black segments. I do apologize for that. So again, I'm just trying to remove another layer of this keratin from that crater, that cave on the mastoid area of the ear canal. You can see how much I'm tugging this. I'm really am tugging this. I'm going backwards and forwards, trying to loosen this keratin. And there's a slither of keratin here that I managed to remove using a suction probe. So you can see kind of the halfway house. You can see on the right hand side, that's his original ear canal. And on the left, this is his mastoid cavity. And I'm just working on the mastoid cavity, just trying to release, still working away. So I have removed quite a lot already. And again, I'm just really tugging this. And you can see it is loosening a bit now. I'm getting a bit of purchase there, and you can see this plug of dead keratin just kind of moving backwards and forwards, up and down, left to right. And I'm probably going to go in with the forceps in a moment. As I've loosened this a bit, and I've created a little tail end, so it's something for me to grip onto. Let's see if I've gone in with the forceps. Yeah, there we are. So again, I'm just trying to get a grip, and you'll see here how much I am pulling at this, but it just doesn't want to come. It's just tearing into little pieces. There we are. I've got a better grip here, but again, it just doesn't want to come out. It's stuck. As I said, it's like a piece of chewing gum. You can just see that plug now. It's beginning to loosen. I think well, it just sliced again, and that's why with forceps, quite often people say, well, why didn't you just use forceps straight away? But again, I'm sorry for the blackout. It's just, I forgot to edit this bit. It was a long video. I'm just scrolling downwards, and that should be the last bit that I forgot to edit, and I do apologize. But yeah, forceps, again, it's not as simple as just putting some forceps in the ear, gripping something and pulling it. There's resistance there. The consistency of that dead plug's skin, it's wet, it's damp, it's just tearing off into little pieces. You can see how damp it is there. It's just fogged up the screen a bit, so you can see all that moisture. So again, I'm just trying to loosen it with the vacuum again, with the suction. Just trying to bring it a bit forwards, and as I do, I will then kind of alternate between the range of ENT micro instruments. So the most common is the suction probe, which is what I'm using at the moment, and this is the Zollner suction probe. We do have a fine end attachment that we can add to the top. The fine end is less suction power, but it's less noisy, so it's less atraumatic for the patient if we become in contact with the canal wall or eardrum. We generally use the fine end for deeper wax and wax that's impacted on the eardrum. You've got a Jobson horn, which is almost like an ear scoop. A Jobson horn is to remove soft wax. An ear hook, similarly, is to remove wax, but hard wax. And forceps is generally to remove, again, firm, hard, or foreign bodies from the ear canal. So they're the kind of 4 or 5 main ENT micro instruments we use. Just wiping the tip of the endoscope there, and again, I do apologise for this blackout. So I've just gone in with the ear hook, and you can see at the top there is a bit of an opening there. I'm just trying to get the ear hook behind that plug of dead skin, and just to kind of extract this keratin. So I'm just going right behind the plug of skin, and you can see how damp it is. It's just slicing through like a hot knife through butter almost. But again, we got a bit out, so slow but steady progress. Just gone with this suction probe to remove that segment of soft dead skin. So this is the original ear canal wall. This is his original ear canal, and you can see we've almost cleared this, and there's a piece of keratin here that I'm using a suction to remove. That should come out in a moment, hopefully. And that should reveal his perforated eardrum. And the problem with this type of consistency of keratin, it can often block the suction probe. So I think on several occasions I had to, the suction probe got blocked, I had to remove it from the ear and use a cleaning rod. So we have like a cleaning rod which we push through the suction probe to clear any debris that's got clogged inside. So we're working near the eardrum there, another piece of keratin, and this part of the ear is becoming a lot easier now. So we're probably about 3 centimeters into the ear canal. You just see how wet and damp that is, and this is a large piece of keratin that I removed. just mopping up near the entrance, and you can just see the perforated eardrum there. When I vacuum this, it should reveal itself. So you can just see his eardrum just to where I am now. Behind that, that's his eardrum, and on the right hand side, and it is very difficult to see because the patient has had surgery, but there is a perforation there to the right. I'm just zooming in there. I hope that was visible. It is difficult, as I said. Patient's had a lot of surgery to his ear, so he's got an abnormal shaped ear canal, but I hope that was visible, that perforated eardrum. So his original part of the ear canal is completely cleared now. That took me about 30 minutes to do, about half an hour. And now we're working on his mastoid cavity again. So again, it's just a lot of the same. Apologise, well, I don't apologise if anyone finds it boring. This is the reality of what I do. As I said, it's not as simple as some people believe it is, or sometimes I probably make out that it is on my videos. And I'm just using the Henkel forceps again, just to remove this keratin. That piece of keratin was a bit firmer, a bit crustier, and lends very well to forceps because you can get a good grip. But softer keratin, spongier keratin, it's not as effective because it just tears it, it just cuts it and shreds it. So just using a standard Zollner suction probe here, and you'll see again I'm going to be switching between instruments. So using the suction probe to bring this a bit forwards, get a leaning edge, a tail, and I'll probably go in with some forceps just to grip on that. Because the top part of this is a bit firmer. You can see that the base of this keratin plug is wet, but the top part is a bit crustier. So if I can get a grip onto that, which I'm not sure if I managed to, no, it's just slicing there. But I will persevere. Oh yeah, no, I managed to get a big piece there. Another piece of keratin. So you'll be quite amazed at the end of the video when I show you all the still images. So you can see there, that's the medial part of his mastoid cavity, very deep in the ear, so that's all clear now. So this plug that we're working on now is just as you enter his ear canal. It's on the left hand side, right near the entrance. You can almost say it's behind the door, so you open the door, behind the door, it's hiding away, it's a bit of a blind spot. But with the endoscope again, we just get such an amazing view of his mastoid cavity. So we can see it, and there's his perforation to the right. Had a little glimpse there. There we are again, you can see that on the right hand side, just in view. And if you're continuing to watch this video, this remaining piece of keratin doesn't look a lot, does it, on camera, but you'd be quite amazed and shocked when I actually eventually remove it, just how much there was. Because again, this client's got a cave at the base of the mastoid cavity, and it's a large trench, and there was a hell of a lot of keratin there, a huge piece. You can see just how much I'm tugging there at the top. I'm just trying to peel this keratin away, and I remember it took me about 5 or 10 minutes to really loosen this, but I'm really trying to bring that forwards. Just as I'm bringing it forwards, it's like a trap door, it kind of slams back. I'm just using the Jobson horn, just trying to get in behind this, but the entrance of his ear canal, because of the cauliflower ear, it's very difficult to extract and retract it, because that cauliflower ear, so also known as a wrestler's ear or perichondrial hematoma, it does make the cartilage almost like bone. It's very stiff, so it's very difficult kind of stretching this ear open, trying to get the instrument in behind. And you can see again, very damp in there, so whenever you lift some of this dead keratin off the canal wall, it just oozes all this fluid or this dampness that's present because of the dead skin. Sorry if any of you are having lunch or your tea or breakfast if you're in a different part of the world. It's not the nicest thing to accompany yourself when you're sitting down to eat. I suspect some of you may have clocked off by now thinking, well, this is a bit too long to watch, but I know there's a lot of people who subscribe and watch that will be watching this right to the end because I think they appreciate what I'm doing here and how complex it is. Of course, some people may be pausing it and returning to this a bit later because I can almost turn this into a movie, couldn't I? Given its length of the procedure. Again, you can just see how much force I'm trying to apply here. But it's just like a rubber band. You're stretching it, bringing it forward, and as soon as you kind of lose the suction grip, it just bounces back. I mean, it was quite plausible at this stage just to end the procedure because the client's symptoms more or less had resolved because that compression, all that, you can see there's hardly any compression now because the rest of the ear canal is clear, it's open. But it's so important to remove this, I felt. He was here and he's not had this mastoid cleaned out for I think 17 years, so we had him on a chair and I thought, and I did purposely book him in the last one of the day because just by him explaining his condition over the phone, I knew it was going to be complicated and I didn't want to run over and keep my subsequent clients waiting. So again, just using some Henkel forceps, managed to remove a piece there, and you can it did shred off, and I've just got another piece, but unfortunately it's shredding a bit, but I think I managed to get, no, it just shredded there. I was hoping that big plug came out in one go. Nonetheless, although I'm shredding it, that is still removing it, so it just means I just have to keep going back and taking little segments out. It's not ideal, it's a bit time consuming, but you said patience is a virtue. You can just see there how it's just sprung back. I got a grip and it literally just sprung back. And again, you can see some contact bleeding. We've not done anything there. We've not kind of cut into the ear canal. It's just as the skin elevates. In a way, it's a reassuring sign for me because it means that I have loosened some more skin off the canal wall, hence the bleeding. You can see the use has gone slightly dark and misty. It's just because of that fluid. So as well as the bleeding, when you do manage to elevate and retract some skin of the canal wall, it just oozes that fluid, that moistness that's present, and it can smear the screen again. But as you can see, I can see everything I'm doing. It's not affecting my ability to perform the procedure at all. So that's 45 minutes so far, so we're in the last quarter now. I think there's another 15 minutes to go. And again, I'll just let you kind of continue watching. And I'm sorry again, it seems like I forgot to edit this part of the video. It's just me going out the ear. And just some advice to anyone who does suffer from keratosis of Turan's and also a mastoid cavity. Do have your ears regularly checked. It's very, very important. You don't want to allow your ears to get to this stage. So do have your ears checked regularly. If you don't have a mastoid cavity and you just suffer from keratosis obturans, regularly instill sodium bicarbonate earwax drops. Sodium bicarbonate works really, really well with dead skin, much better than olive oil. Olive oil is my first port of call for earwax, but not so much for keratin. I find sodium bicarbonate works exceptionally well. Obviously, if you have a perforation, you shouldn't be using drops. Just some regular ear care advice as well. So, I mean, I don't really have a substantial buildup of wax, but I still use olive oil spray actually, which is designed for earwax. It's not your home extra virgin olive oil. I know over centuries people have been using that type of oil, but you do have specially treated, chemically treated oil now available over the counter, specifically for earwax, which is kind of designed for the ear. It's a medical device, so it's purified, it's safe to use in the ear. And I instill drops every 2 weeks. Put it in one ear at a time. So put it in one ear, I tilt my head so the ear that the drops are in is tilting and facing towards the ceiling. I let it penetrate for 5 minutes. I then come back the other way and allow these drops to drain. That's important. Let these drops kind of come out of your ear. If not, it will just soften wax and the wax will drizzle further down towards your eardrum. So you just put a tissue underneath. And you can do the opposite ear the following night. If you do the opposite ear immediately afterwards, when it comes to draining the second ear, some of the oil in the first ear will kind of re-enter the ear and drizzle further down. So one ear per night, once a month. I do it every 2 weeks. And the concept is that you're trying to rinse your ear out using olive oil drops, because you can't rinse your ear using water. Water is bad for the ear. It's a big no-no. Water in the ear can cause otitis externa, outer ear infection. Olive oil and sodium bicarbonate drops are a lot safer to use. It's not to say that you can't develop infections using those drops, particularly sodium bicarbonate, because that has got a bit of water in and it's slightly alkaline, whereas the ear is slightly acidic, and olive oil is slightly acidic. And the concept is prevention is better than cure. Use the drops regularly to rinse out any small pieces of wax and soften it before it kind of builds up. And the oil itself will help lubricate the ear canal wall. So it provides some natural lubrication to help the natural migration of wax. So wax migrates out of the ear in the following way. So the skin that coats the ear canal, near the entrance in particular, has sebaceous and ceremunious glands. These glands secrete wax and some of the compounds of earwax, and as they mix, it forms earwax. These glands are typically only found in the outer third of the ear canal. And as the skin sheds, as I said, the skin sheds like a snake skin, this wax naturally expels, it migrates outwards, and then you have another layer of skin underneath growing and shedding, and again that fresh layer of skin will secrete more wax. And oil in the ear can help the natural migration of that skin and therefore the wax. So just going back to the video, so I've just about managed to get this plug out from that trench, that crater in its mastoid cavity on the left hand side, and you can see how big it is. And you would think this is it. Once I've got this out, that is all that's in the ear left. But you'll be surprised to learn that once I've got this out, there is another big plug of wax, I believe, or not wax, dead skin. You can see how white this is. It's all fresh keratin, and I'm just using a suction probe, just trying to loosen the ends off, wriggling it forwards. Remember, this plug of skin is much, much larger, probably 4 or 5 times larger than the client's ear canal entrance. And also it's important to remember this patient, he attended with earache, so he was already in massive amount of pain as he attended, and we weren't using any anaesthetic, no local, no general. And you can just imagine how well he tolerated this procedure. You can see how hard we're working in here and how long we've spent in there, and all this kind of tugging and pulling and lifting of skin off the canal wall. And again, he was really cheering me on. just begging me almost to continue and just finish the job off for him. I've got another 10 minutes left. I forgot I had a Zoom meeting at 7 o'clock with my Clearwax colleagues. I'm just going to continue editing this video, and I'll apologise to them for joining late. I spent 50 minutes already narrating, so I'm not going to stop now. Just hopefully it's only, I think, less than 10 minutes to go. And again, you can just see this plug of skin is near the entrance of his ear canal. We're just trying to pull this through. You can see just how much of a tug of war this is, just trying to squeeze this through his narrowed ear canal. So I'm just using the forceps again, just trying to extract this plug, but the problem with forceps, as I said, sometimes it just shreds this keratin, but in this instance I've managed to hopefully get this plug out. Yeah, it's a big piece there. Just going back in to get the tail end of that plug and see still a bit more. So forceps weren't really cutting the mustard there, it was just shredding it and actually pushing it back in. So I've just gone back in with the suction probe, just trying to bring it to the entrance of the ear. And again, it's a combo of instruments we're using, so bringing it to the entrance, and I think I might go back in with the forceps. Once it's at the entrance, I can grip it and pull it. Or with this piece of keratin, I may have managed just to vacuum it out because it's a bit softer and it's a bit more pliable. Now, using the forceps again just to pull that through, but again it just sliced it into a smaller piece. So going with the Jobson horn, just trying to get in behind that plug, and there we are. I've managed to get some of it through the ear canal. It's quite damp, quite moist. There we are. So you can see, you probably saw how much force I was applying there to get this through. And as I said, this piece of plug is about 4 times larger than the entrance. So although it is spongy and soft, it still requires a lot of penetration and force to get behind it and kind of bring it forwards. That's where the Jobson horn helped. Just going to mop up near the entrance there with the suction probe, another piece of keratin. So it's almost like a magic trick where the magician has a handkerchief underneath their sleeve, and they're pulling, continuously pulling this handkerchief, handkerchief upon handkerchief, and it's like similarly with this ear, it's a never-ending ear. You keep pulling this skin out and out, and just as you think there's no more skin, there's another piece. You can just imagine how fatigued my hands were at this stage, but I was still able to get a very steady view. So I'm holding the eye clear scope, the endoscope with my left hand, and the instrument I'm holding in my right hand. So there's a bit of bleeding there, but it's a bit of keratin as well, so just going to suction that through. I think the patient joked as well. Obviously, the patient's never been in labour himself, but he did say he imagines what this would be comparable to giving birth, as every time he was having these plugs removed from his ear, he was just finding so much relief. So it wasn't a nice sensation for the patient, but it was coping very well indeed. And just trying to get in behind using the Jobson horn again, but fortunately it just pushed that back in a bit. So I'm probably going to have to go in with the suction probe again and bring this forwards because it's a bit deep. Yeah, here we are. So I'm just going to bring this forwards again. You can see it's quite, you get a reflection, so keratin's white. When we have light shining from the endoscope on a white surface, you do get reflection. And that's why it's so bright at the moment, because it's like with any object, so white objects reflect light more than dark objects, and that keratin was so white it was causing a glare. Still struggling to get this last piece of keratin out of the ear, but as I said, perseverance, patience is a virtue. And you can see that movement I'm using with the suction probe. I'm just wriggling, going round in circles, trying to squeeze this out of the ear canal entrance. Just trying to get a different angle there to see if it helps. So I've just gone to the base inferiorly, trying to lift this plug upwards. Do you remember he's got that trench, that cave? So just trying to lift it upwards so the base of this plug can kind of be released. And I've just gone a bit deeper in with the suction probe, trying to get a bit of a suction grip on a bigger piece of the plug, and there we are. That's a big piece. I think there's still some more in there, believe it or not. Yeah. Another huge piece. And all this was hidden away. It was all hidden away in that trench, that cave, in the mastoid cavity. If you remember what I said earlier, you'd be quite surprised, because when I removed all the debris and keratin from the original part of the ear canal, when you were visualizing what was left, the remnants, it didn't appear like a lot. But I did mention at that time, you'd be surprised later on in the video just how much there was. Again, it's just gone a bit blurry. I'm just really tugging away at this. There's a few cilia, a few hairs at the entrance. People often say, why don't you cut them, why don't you trim them? Well, I don't really need to, it's not affecting me. With any procedure, you only do a procedure if it provides clinical benefit, and it may not make best viewing, but I'm not making these videos for the sole pleasure of people watching it. I'm doing it to help a patient, and it's a clinical procedure. So there's absolutely no need, in this case anyway, to remove those hairs. Again, just this last plug of keratin. Just trying to rotate this keratin, just trying to reposition it. You can see I'm just lifting it forwards from that kind of crate to that base. Just turning it to see if it's almost like when you're trying to move a sofa from one room to another. Hi guys, sorry if the sound cut out there. The software that I'm using just timed me out. The narration is only allowed to be for certain times, so it kind of paused me and asked me to save that and start recording again. So sorry if there's a little brief moment of silence there. Yeah, and I was saying before, so sometimes with wax or keratin, you have to reposition it. So it's like when you're moving a piece of furniture from one room to the other, you just have to get it in that right angle, because obviously that sofa or bed is larger than the door frame, and you have to get it in the right angle to kind of allow it to be maneuvered through the door into the other room. Just using an ear hook now, just trying to get in behind this plug of keratin, which I have. I think this is probably the largest piece of them all. Let's take a look inside. So, bit of keratin still there, you can see. There's not a lot there though now. I've got the majority of out. And this is that cave, that trench I was talking to you about. It's a lot more visible now. And this keratin, this spongy skin, you can see how spongy and elastic it is. When you vacuum it, it just bounces back. It doesn't want to come out. You can see all that white keratin. So I'm going to remove the majority of this. We're nearing the end of the video, and you'll see at the end of the video I had to stop. It's just because the patient was getting a bit dizzy. He was experiencing the caloric effect. So when we vacuum the ear, people can often experience a bit of vertigo, and that's because the vestibular system, the balance organs, are located in the inner ear, and cool air, which is what the suction probe introduces into the ear, can inhibit the balance organ. And remember, we've got two balance organs, so the balance organ in this particular ear is being inhibited, so it's kind of being almost suppressed, and the opposite balance organ is functioning fine. So the brain's getting mixed messages from both ears, and so therefore it believes that you're moving but you're not. And then people suffer from vertigo because your eyes then trying to correct your ears, and your brain telling your brain that you're not moving, it's just your ears playing a trick on you. And that can happen either if you introduce a cooling effect in the ear or a warming effect in the ears. If you increase the temperature, it's called the caloric effect. Near the end he did get a bit of faint, but it's short lasting, but nonetheless the procedure is long enough as it was. We've done our job. Just trying to remove a bit more keratin of this crater. You can see it there. We're not trying to remove every single last bit. This procedure's gone on quite a long time already. Just some bleeding blood there, just vacuuming that. So that's that cave, that crater caused by his mastoid surgery, and there's the eardrum to the right. You can see it's a bit damp in there again. That dead skin, it is still a bit oozing a bit of fluid. It's not coming from the perforation, it's just a dead keratin. This is a final view, so there is a bit of keratin left here and there, but you can see how well we've done. We've really removed that. It's perforation visible there. And as the patient's wife at the beginning of the video stated, the patient is now a human being. He's back in the land of living. So this is some of the still images. You can see just how much we removed. You can see all the instruments there we used suction probe, Henkel forceps, ear hook, St. Bart's ear hook, a fine end. We went through the whole repertoire of instruments there. And that's it, guys. I hope you enjoyed that. I hope it wasn't too boring for some of you watching, and hopefully I'll upload some videos shortly. Take care, bye.